Hello and welcome to this edition of Great Discoveries. We will look back to the most important innovations in the field of cardiovascular medicine, meeting the people, the personalities, the brains, the ideas behind these innovations to better understand and to explore a little bit why things happen and how the quality of cardiovascular medicine was so tremendously improved by such innovations. My name is Hindricks from the Heart Center Leipzig in Germany. I have the privilege to host this edition and to welcome Professor Alain Cribier from Rouen, France, one of the most influential interventional cardiologists of the last decades. Alain, welcome so much to this edition of Great Discoveries. It's a privilege and pleasure to have you with us and to explore a little bit and to learn from you what drove you and your team to make these tremendous improvements in the quality of care of cardiovascular medicine.
Well, thank you, Gerald. It's a pleasure to be with you.
Excellent, great. When I looked to your career, I learned that in the very early days of your career, actually as a medical student, you started as a student assistant in cardiac surgery. We must have been in the mid 70s around that, or maybe in the early 70s. And despite that experience in cardiovascular surgery, you decided to change to cardiovascular interventions, to cardiology. What inspired you to make that change?
I started doing a lot of cardiac catheterization, and then my road was moving towards what was new in this field, and starting with the PTCA with Brunswick and the dilatation of coronary arteries and so on. And I started to be really interested by interventional cardiology.
How important on that path was the time in Cedars-Sinai with Swan and Gans? I think you stayed 1 year there.
Yes, I stayed 1 year, but it was the most important year in my career as a medical student, at least, because these people were extremely clever, and they were pushing people to innovate. There was a world of innovation, everywhere in the laboratory, and they were really looking forward to get any kind of Nobel Prize in innovating technology innovations. And they teach me how to do really fairly good research, how to manipulate data, how to be very frank with the results, and publishing and so on. It was absolutely crucial in my career.
Mm-hmm. And with your first innovation, you focused on aortic valve stenosis, and the key intervention was aortic valve valvuloplasty. That you were the one who did that first on this planet to a patient. Why was aortic valve stenosis so important for you that you focused your development strengths on that field?
Well, actually, I have been working in innovative technologies in coronary artery disease first. And then I was really fascinated by the fact that many people were dying in the cardiac department where I was working of aortic stenosis. Aortic stenosis was very frequent, and at that time, we are in the very early 80s. The surgeons refused to operate on patients older than 70 years of age, for example. And so we could see the people, coming back to the department, on every month, with cardiac failure, with symptoms, and they were finally dying because they were declined by the surgeons. So I said, well, something should be done. And I was thinking that maybe inflating a balloon inside the aortic, the calcific aortic valve would be enough to at least, relieve the disease, relieve the symptoms, and maybe increase the life expectancy of patients who were all very threatened. Yeah. So I did the first balloon aortic valvuloplasty against the opinion of my boss. He was against it, so I very often, I came back to him and said, we should do that, we should do that. And we had a patient, a 72 years old patient who was extremely symptomatic. He came a number of times. He was declined by surgeons. He was only 72 years of age. And so finally, I could perform the first balloon aortic valvuloplasty, and I was very lucky because the result was absolutely fantastic. You know, with a small balloon size, I could really increase the valve area, and all the symptoms disappeared. We called back all the patients who had been declined by the surgeons, and we did the first paper published in the Lancet, which was a long effect in the medical community, and everyone wanted to do a balloon aortic valvuloplasty.
Yeah, and I need to know one thing, Alain. When you do such disruptive innovations, and when you are in the forefront of the first in man case, you induce resistances. There's a lot of criticism. People are going into opposition. I can imagine that not all the cardiac surgeons were delighted by the idea to do that as a transcatheter position. You need to be really strong and straight in staying on track. How did you cope with such things?
Well, you know, it was a very difficult period of my life because I had to struggle against cardiac surgeons, and it was very tough, you know, during the meetings and in public. You know, they were accusing me of trying to kill the patients or trying to make money with devices. You know, this was absolutely frightening. And because of the results that we had, you know, they had to be finally convinced that something could be done in elderly patients and that we could relieve the symptoms, can really improve the situation. And you know, when you do something like that, you have to believe in yourself. You have to believe in your own ideas, and also you can catch, you know, the support of the people who are working with you, close to us. You know, I was working in a fantastic cardiac team. With people very open to innovative technologies, starting with my boss, Professor Letak. You know, he was pushing me and he was really encouraging me. And you have to have people like this behind you. You know, when you against the whole community of the cardiac surgeons who are against you. So, well, one of the interests of balloon aortic valvuloplasty was to convince the surgeon that they could operate on elderly patients. You know. And so since we started balloon aortic valvuloplasty, the surgeons started to operate on patients older than 70 years of age, and they demonstrated that they could do a good job. So this was a very positive effect of balloon aortic valvuloplasty.
So the team around you gave you the strength and the confidence that the development needs to be further explored and needs to be pushed forward. Then when we look to the further course of aortic valve valvuloplasty, few years after the introduction of the procedure and then the use of the procedure, there was the issue of valve restenosis. Was there hesitation? Was there disappointment? Was there fear of failure? How did you handle that phase?
Yes, it was also something that I felt kind of early in the course of this experience. After 3-4 years, you know, I realized that patients were coming back with stenosis, and you know, tens of thousands of patients have been treated in the world. We had big registries in the United States, like the Mansfield registry, the NHLBI registry, and some thousands and thousands of patients, and they all came to the conclusion that we could improve the symptoms, but after 1 year, you know, the restenosis was here. And so I said, well, either we stop there or we invent something else to try to find a solution against restenosis. And came the idea of a stented valve, which was the only possible way of implanting a valve inside the diseased valve using transcatheter technique.
Yeah. How many years did it take you from the moment where you recognized that valvuloplasty is not the solution and that you need to develop a stent-based valve?
Yes, more or less between 8 and 10 years. You know, wow. The first time that I announced that we should implant a valve was in 1994. I did anatomical studies on cadavers to demonstrate the concept of stented valve, and it was extremely positive. So we spent, I would say, almost 10 years, you know, to try having a prototype in our hands and to implant it in animals and to think about the first case.
Yeah. Case. On that track, from the idea of developing this valve until the first in man case that you did in the early 2000s. Was there this one moment that you can recall where you were convinced we will succeed, it's going to happen?
Yes, well, absolutely. The first animal was the first sheep model was implanted in the inside the aortic valve, and by chance, it was extremely successful. I understood that the whole thing was good. Also, the anatomical studies that I practiced on cadavers were very positive. So I was absolutely convinced about the possibility of doing this.
Mm-hmm. Meanwhile, a couple 100,000 patients have been treated with transcatheter valve replacement. Your technology has saved 10,000s of lives all around the globe. It's one of the most significant innovations that we have seen in the last decades. Looking a little bit ahead for my last question of this interview, where do you see the next big field in the field of transcatheter valve therapies, Alain?
Well, actually, today we have more than 1 million people treated in the world, in 70 countries. So I think all the studies have shown that we could use technologies even in patients who are good surgical candidates. And the next step will be probably to improve again the technology to make it again easier if possible, and to determine very precisely who are the good candidates and who are the candidates who remain better candidates for surgery.
Alain, thank you so much for sharing the time with us and to giving us insights into this absolutely fabulous journey in innovations in cardiovascular medicine. It's an honor and a privilege to have you in Great Discoveries. Thank you so much.
Thank you. Thank you very much, Gerald. Thank you.
Excellent. We thank you for your interest in Great Discoveries here at the ESC. Stay tuned, stay with the ESC, stay with us. We are there for you with more to come.